Good morning and welcome. My name is Megan Seiss. I'm the Director of Onconephrology at Mass General Hospital and an Associate Professor at Harvard Medical School. And I'll be chairing this session here today where we're going to talk about personalizing care for patients with cancer. And each of our speakers is going to talk about some issues that are specific to patients with cancer. Dr. Paul Hanna, who's the Director of Onconephrology at Medical College of Wisconsin, is going to talk about how we think about and personalize EGFR estimation in patients with cancer. I'll be talking about some challenging issues with making decisions about treating immunotherapy-associated acute kidney injury. And Dr. Murakami, who is an onconephrologist and transplant specialist at WashU, will be talking about treatment decisions that you make in patients who have cancer and are transplant recipients. So I'll invite Dr. Hanna up to the podium.
Thank you and good morning. The title of my talk is Estimating GFR in Patients with Cancer. These are my disclosures, non-relevant to this talk. Our learning objectives are to describe the key findings of the OncoGFR study in assessing kidney function in patients with solid tumors, then explain the relationship between sarcopenia, or low muscle mass, and GFR discrepancy in patients with cancer, and lastly, demonstrate the impact of medication side effect in patients with cancer whose creatinine and cystatin C levels are discrepant. So I believe this is a kidney-centric audience, so hopefully I don't have to remind you, I don't have to convince you of the importance of doing an accurate kidney function assessment in patients with cancer. But just to remind ourselves, these are important measurements to determine therapy eligibility. A lot of times chemotherapy dose adjustment, and I've listed a few of the chemotherapies here, highlighted even fewer ones, methotrexate, for example, pemetrexed, etoposide, and platinum therapy that I will describe a little bit later. There's definitely a lack of data in the CKD population in patients with cancer, as typically those are excluded from studies. There's also some drug effects on GFR. For example, if you think about some of the newer agents like CDK4/6 inhibitors, they may cause elevations in creatinine without another elevation in cystatin C, leading to pseudo-AKIs. And obviously, last but not least, clinical trial enrollment. Most of the patients, unfortunately, if their GFR is less than 30, sometimes 45, they're excluded from clinical trials, which is really important to continue life-saving medications. What are some of the challenges to GFR estimation in patients with cancer? Well, unlike our normal other populations, we have reduced muscle mass and sarcopenic patients, especially when the cancer takes over. When you think about the last patient that you saw with pancreatic cancer, for example, the amount of cachexia, the amount of wasting that you see on their body as soon as you walk into the room makes you think that this patient doesn't have enough reserve, doesn't have enough muscle. Yet, when you look at their labs, their creatinine is perfectly 1. To me, that seems a little bit out of picture because it should be much lower than that. In addition, our patients, especially those with liquid cancers, are constantly in a high pro-inflammatory state, leading to elevation in their haptoglobin LDH, as well as other inflammatory biomarkers, such as cystatin C. So that also gives you a little bit of an accurate estimation of their GFR. Nutritional status affects creatinine, obesity affects cystatin C, and obviously if there's any nephrotoxicity, as we described earlier with CDK4/6 inhibitors, that only affects creatinine but not cystatin C, there's discrepancy there. So all in all, there's no perfect biomarker, and this slide is designed to show you that either cystatin C or creatinine, they're not perfect alone. They may be a little bit better together, but certainly requires a little bit more thought, especially when we're thinking about medication dosing. Then I'm going to tell you a story of how we, Dr. Seiss and I, got involved with the GFR estimation. In 2002, this great study, OncoGFR, which is a prospective cross-sectional study out of Brazil by Dr. Costa e Silva, looked at estimated GFR from creatinine and cystatin C, compared it to measured GFR in these patients in about 1,200 adults with solid tumors. Dr. Seiss and I were asked to write an editorial on it, and we took that opportunity to look a little bit closely at the studies out there and the equations that we have to estimate GFR. This is a table from that editorial that we wrote, and it's adapted from the original study that was published in KI. They defined bias as the median difference between measured GFR and the estimated GFR based on whatever biomarker they were using, either cystatin C or creatinine. They defined accuracy as 1 minus P30, which is the percent estimate that differed by more than 30% from the measured GFR. Quickly looking over the table here, I've highlighted the combined equation looking at creatinine and cystatin C in these patients with the CKD epi that was developed in 2021. Bias was the least, and accuracy was actually pretty good. So this tells you that when we look at patients with cancer, the closest thing that we have to perfection, which is the measured GFR, is the combined equation using both cystatin C and creatinine. And this is the graph that they had in the original study, and one that Dr. Saiz and I looked at for months because we loved how it summarized a ton of information. Let me quickly orient you. The dotted line here, let me try and use the pointer. Oh, perfect. The dotted line here is the measured GFR. And this is in comparison to so GFR based on creatinine and GFR based on cystatin C, and then the combined equation. Over on the left, this is overestimation of GFR, and then on the right is underestimation. So you can quickly tell that whatever impacted creatinine negatively somewhat impacted cystatin C positively, thereby giving you a perfect balance with the combined GFR. Now, is this absolutely true all the time? Well, as with everything in medicine, not really. There's always the exception. The exception here is extremes in body composition or BMI. For example, when you have BMI less than 20, creatinine did overestimate your GFR. Cystatin C basically give you a perfection here, which is GFR based on cystatin C that closely matches the measured GFR, but then when you do the combined equation, it's not so accurate anymore. Again, with BMIs that are more than 30, you see that the creatinine is underestimating, cystatin C is largely overestimating, but thankfully the combined gives you the closest match. So there's definitely a story to be told there, and I'm going to come back to it at the end of my talk. The other thing that I wanted to highlight here is with the transitions in CKD definitions, you see a little bit of discrepancy here between measured and creatinine, measured and cystatin C. Now, one might think that the combined equation would solve this problem. Unfortunately, it really doesn't. And this is really important because if you're basing your decision slowly on one GFR, whether or not patients should receive therapy, whether they have CKD3A, 3B, or CKD4, then this tells you that that decision may not be so accurate, thereby limiting access to life-saving treatments. The other point I wanted to make is in these patients that are high risk with metastatic disease and those patients that are highly functional, you tend to see that perfect balance with the combined, mostly because it tends to balance out the inflammatory state of creatinine with the sarcopenia the inflammatory state from cystatin C and sarcopenia from creatinine, giving you close as possible to measured GFR. Again, with functionality here, because as you know, those patients, the ECOG scores that are a little bit higher, that means they're able to do more. They're able to have a muscle mass. And that means that they're able to actually perform better. So taking this to our lab, in a cohort of 1,900 adult patients, we looked at GFR discrepancy and defined that as GFR based on cystatin C that's more than 30% lower than creatinine. In our cohort, we found about 30% of these patients, 543 patients, that were discordant. Our hypothesis then was, in these patients with the discordant GFRs, they would be at highest risk for medication errors and side effects. This is our risk factor table. And again, there's a story to be told here with the extremes in BMI and body composition, where when you have a low BMI, that kind of favors discrepancy. And when you have a higher BMI, that also favors discrepancy, not at the same rate, but there's something here. Obviously, with cirrhosis, this is just a quick example, you tend to lose a lot of muscle mass just because of liver disease alone, so that makes sense. You have discrepancy between GFR, cystatin C, and creatinine. Well, what about biomarkers and risk factors that could potentially signal a discrepancy in our patients? Well, as you know, and you've probably taken care of many cancer patients, these patients require, unfortunately, a nutrition consultant admission, someone to follow them nutritionally outpatient, as well as a lot of blood products because of their anemia. So to orient you, the line here, the dotted line here is what we call the line of equality. Basically, GFR based on creatinine, if you go up to the line, it matches GFR based on cystatin C. What we see here is with the black dots, I'm going to take it all the way down to the extreme, albumin less than 3, we see most of the black dots down here, telling you that if a patient with hypoalbuminemia coming in with a normal GFR based on creatinine, probably they have a discrepancy based on their cystatin C. Most of the greens, most of the normal albumin aggregate around the line of equality. And in between, you have mild hypoalbuminemic. The same signal you see here with hemoglobin. In patients that are severely anemic, and they're all below the line of equality here, their GFR based on creatinine does not necessarily match their GFR based on cystatin C. Well, there again, when they are not as anemic and they're actually living in the normal ranges, most of these patients will live around somewhere along the line of equality, and they have concordant GFRs. So this is a quick poll. In patients with cancer, large discrepancies between GFR based on creatinine and GFR based on cystatin C may, A, cause misestimation of drug dosing of life-saving treatments, B, signal inpatient mortality within 30 days, C, lead to medication adverse effects from commonly used medications, or D, all of the above. I'm going to open the poll here. All right. So, absolutely correct, all of the above. And let me show you why. We took our study to a new level that has never been done before. Most of the earlier studies actually looked at the discrepancies between cystatin C and creatinine, but we actually took it one step further. What does that mean in terms of clinical care? What does that mean in terms of medication adverse effects? In our population of 1,900 patients roughly, we found patients that received vancomycin with levels that are measured. About 235 patients received Bactrim, and they have potassium measured. 31 patients receiving baclofen, and 34 patients receiving digoxin with trough levels. And the results were astounding. With the vancomycin, if we go all the way down here to more than 40 microgram per milliliter, which is very, very high dose toxic doses, we see that most of these patients, actually all of them, had discrepant GFR based on cystatin C and creatinine, none of the concordant patients here, and none of the flip side where cystatin C was actually better than creatinine. And then we see this beautiful graduation. We see this beautiful bar graph where as we go a little bit lower, we see more of the cystatin C discordance with creatinine, not so much with the concordance, and not so much where the opposite is true, where cystatin C is a little bit better than creatinine. The reason we don't necessarily care too much about the GFRs based on cystatin C that are better than the creatinine is because these are the patients that are typically on creatinine secretion blockade. For example, patient is on cimetidine or patient on CDK4/6 inhibitor where they have a pseudo elevation in creatinine, but not necessarily their cystatin C. So their true kidney function is actually okay. Same signal here we see with grade 2 or 3 of hyperkalemia with Bactrim. And these are defined by the CTCAE guidelines. Those are the guidelines that our colleagues in the cancer world use on a daily basis. Here we see that potassium more than 6, more in the discordance than the concordant, and obviously more than 5.5 of potassium, you see the highest in the discordance GFR cystatin C compared to creatinine. What about baclofen toxic effects and digoxin toxic effects? All the patients with discordant GFRs, I don't see any light blue or white bars here, which means all of these patients actually in both groups were found in patients that have discordant GFRs. But to orient you, orthostatic hypotension, altered mentation, very common with baclofen, only happen in these patients where they were misdosed because their GFR was not concordant. In fact, we had a patient that also had clinical digoxin toxicity, and that patient required ICU admission, and they had multiple EKG changes. This is mostly because they were misdosed. What about mortality? That's the most common question our oncology colleagues will ask. Well, you talk about clinical, outcomes, but mortality, that's what we care about. Well, if you look at those patients that have discordant GFRs, you found that they have an increased risk of death within 30 days of inpatient. When you look at patients with concordant GFRs or those who have cystatin C a little bit better than creatinine, those match and they don't have an increased risk. So even with death, even with mortality, when you adjust for all the other comorbidities, medication use, and everything else, patients with discordant GFR are at higher risk of mortality within 30 days of being inpatient. Now I'm going to bring it back to the original paper and try to explore that relationship that we found, that body composition that we found with the original paper, looking at extremes of the BMI here. We're so lucky that where I trained, we have Dr. Fentelman, part of the interventional oncology group, looking at body composition analysis of L3 with CT scans. And he looked at a few things. But to orient you, this is a patient with cancer, normal L3. I've colored here a few things for you. The red is the skeletal muscle, the yellow is the visceral adiposity, and the green is the subcutaneous adiposity. And this is a patient with sarcopenia, where you can effectively tell that the red was pretty much eaten up by green and yellow visceral and subcutaneous adiposity. So this is the patient that you walk into the room, you don't find a lot of muscle mass. You try to grab their thigh or try to examine their shoulders. They don't have much there, no muscle mass, but they do have a lot of adiposity. In our cohort, we found 662 patients with abdominal CTs available. So we basically ran them to Dr. Fentelman and can you run analysis on this? And he was able to run 445 patients. But in order to do that accurately, we have to define what sort of measurements we're looking at, what sort of criteria we're using to tell if someone is sarcopenic or have low muscle mass. And the measurements we use here, there's different kinds of measurements that were described over the past few years, but the one that we found the most helpful was the one defined by Prado in 2008, and that is basically looking at skeletal muscle index, and that is the skeletal muscle mass standardized to height. And as a specific number for males, it was 55, and specific number for females was 39. So if we plot over our patients, if we plot their skeletal muscle mass, noted here down below on the x-axis, and we took a look at what happens with this is the true difference between GFR based on cystatin C minus creatinine. This is not a percentage anymore. This is just difference, just how different the numbers are. In severe sarcopenia, as the skeletal muscle index decreases, the difference is also increased. So normal muscle mass, as we approach normal muscle mass, the difference between the cystatin C GFR and the creatinine GFR approaches zero. So to reiterate, those patients that have severe sarcopenia, they're prone to have the largest difference between their GFR based on cystatin C and GFR based on creatinine. So another poll here then, in these patients with cancer, what are the highest risk for in terms of GFR discrepancy? Are those the patients that have sarcopenia but no obesity? Or the patients that have both sarcopenia and obesity, or the patients that have sarcopenia and obesity? All right. Perfect. I think all of you got it right. The sarcopenic obese patients. And those are the patients that we see the most eGFR discrepancy in terms of discrepancy between cystatin C and creatinine. This is just looking at our data that was later validated with unpublished data as well. But the most patients that get into trouble are those patients that you walk into the room, you see high adiposity, most likely because of years and years of steroid use, but no true muscle mass, and they're not eating, not drinking, and they're just malnourished. And these are these patients down below here, where their muscle mass was effectively taken over by the adiposity. We then went back to the OncoGFR trial, and Dr. Seiss actually led the effort collaborating with Dr. Silva and Dr. Fintelman. This was a prospective study, unlike the retrospective studies that we did earlier. It was designed to look at measured GFR, not estimated, and this is the key difference here. Measured GFR using plasma clearance of creatinine EDTA and comparing them using abdominal CT scans within 90 days of the measured GFR. Study also out of Brazil, about 500 patients. Orienting you quickly, the dotted line here at 0 is where the measured GFR equals the estimated GFR based on creatinine. And what you can immediately tell here is that with the severe sarcopenia patients, creatinine overestimated GFR largely more so than the patients that do not have sarcopenia. So approaching normal skeletal muscle mass and even higher than normal skeletal muscle mass, we see very minimal overestimation. But in these patients that lack muscle mass, creatinine has a large bias to overestimate them. What about cystatin C? Well, with cystatin C, we didn't see much of a strong association here, but we did see scattered points, scattered plot. So it does lack accuracy and it does lack precision, but maybe, just maybe, there's a little signal here that tells us that cystatin C underestimates measured GFR in patients with cancer, but it wasn't clear enough. Well, what happens when you combine both equations then and look at the body composition analysis using measured GFR versus creatinine / cystatin C? Well, here we found that we still have, it's a little bit better in terms of precision and accuracy, but it still found that creatinine still overestimates measured GFR. Now, why is that important? That's important because even when you use the combined equation, it is not the true and end-all test. If you can get a measured GFR in patients with cancer receiving medications that can be renally excreted or have side effects from a kidney standpoint, then measured is the gold standard. But as we can tell, not a lot of centers in the US that actually have access to measured capabilities. And this is the last research I want to highlight. This is a very cool study that was done by Dr. Joshwan Liu from our group, led by Dr. Seiss, that looked at prospective study of about 450 patients with cancer beginning cisplatin or carboplatin therapy. If you remember my first slide I showed you, those are medications that are very helpful in patients with cancer to treat the cancer. Unfortunately, they have to be kidney dosed because of how chemotoxic they can be. And in these patients, looking at the side effects that may occur, as one may expect from overdosing, looking at anemia, thrombocytopenia, AKI, and all hospitalizations, we can immediately tell that patients that have discrepant GFR, and this is defined in this cohort by serum creatinine divided by cystatin C less than 0.7, they had the most anemia, thrombocytopenia, and grade 3 AKI. Now, this is important because these patients, 450 patients, used standard therapy, standard regimen that used Cocker-of-Gold equation to estimate the amount of chemotherapy they need to take. Unfortunately, this is common practice, and this is what we all do right now. There's not enough pull in the cancer world to actually start using cystatin C and start using measured data. But if you talk to your friendly pharmacist, unfortunately, all of their data is based on Cocker-of-Gold. Is that the super accurate, most relevant in this patient population? Not really. Again, mortality for our colleagues from oncology who really think that everything comes down to mortality. If we look at this, the lines separate too early, in my opinion, when you look at 90-day risk of death in patients that are discrepant versus the patients that have concordant GFRs. So although these are only associations that I'm showing you today, they do signal the importance of estimating GFR in patients with cancer, because without it, then it would be either overdosing our patients causing toxicity or underdosing them and not giving them the benefit of anti-cancer therapy. So in conclusion, creatinine-based GFR may overestimate the true and measured GFR in patients with cancer, while cystatin C may actually cause the opposite and underestimate it. CD abdominal imaging in obese and sarcopenic patients with cancer may signal very large GFR discrepancies, which leads to, or actually be almost like a biomarker for potential more adverse effect later on. The 2021 CKD-EPI combined equation is the most accurate and least biased, though, as I've showed you in the last few slides, it is not by all means the gold standard. Measured is. GFR discordance between creatinine and cystatin C is common, and having cystatin C that's lower than 30% is linked to adverse effects in all medications, especially those cleared by the kidneys. Serum creatinine over cystatin C discordance is associated with platinum adverse effects and death within 90 days. And this was the data that was presented yesterday. I hope you were able to catch it by Dr. Joshwan. With that, I will conclude and I will entertain any questions. Thank you.
Awesome. Thanks so much, Dr. Hanna. We do have a question from the Q&A, and someone has asked, how does GFR, and maybe you can comment on GFR discrepancy, how would that vary over a course of someone's treatment, chemo treatment? What would you expect? I think that data doesn't exist, but what would you expect?
Well, we do have one study that was actually done by Dr. Tariq Shafi that looked at variations, individual variations within one hospitalization, and it does vary a lot, every day. With dehydration, with medication use, the GFR may vary for the same patient on a day-to-day, sometimes within the day, kind of every lab check basis. So with that, I think the most accurate estimation that we can use is when the patient is in a steady state, hopefully before the start of therapy, that we can actually estimate what the true GFR is. In these situations, having access to measured maybe once or twice wouldn't be the worst idea in the world. In fact, it may be the type of information that you exactly need to be able to redose those medications for these patients.
Great. All right. I'll be speaking today about treating immunotherapy-induced AKI, and we're going to talk about the ways we have to personalize this treatment and the sort of one-size-fits-all approach that doesn't work, given how complex patients' cancers can be and their side effect profiles. These are my disclosures. We're going to try to understand how important accurate diagnosis is as the first step in personalizing management, is making sure we have the right diagnosis. We'll talk about the role of other AIN meds like PPIs and antibiotics and NSAIDs that trigger AIN, and we're going to talk about ways that you can personalize treatment approaches. So for a starter, this is, up until 2023, this is all the checkpoint inhibitor FDA approvals, and you can see that it just continues to expand. There's new indications every year that are added. There are now over 100 indications for checkpoint inhibitors. And what I also have outlined here in red, we're going to come back to this, is all the cases where patients with early stage cancer, got approval for checkpoint inhibitors. So it used to be that we only saw patients with metastatic cancer, and that's a big branching point in how you approach a patient, is whether their cancer is metastatic and could kill them versus whether they are cancer-free and just receiving an adjuvant therapy. So that's a really big point of personalization of care. So a third of patients with cancer qualify for an immune checkpoint inhibitor. So if your nephrology practice is connected to a cancer center, or you see referrals from the cancer center or inpatients from the cancer center, then you are going to run into these patients because a third of them are getting checkpoint inhibitors, and we know that checkpoint inhibitors cause renal side effects. These are called immune-related adverse events, and that's because they're not like typical nephrotoxicity where we think of patients receiving chemos that are tubular toxins and they get, AKI from that. That's typically acute tubular injury. These are autoimmune side effects. Immune-related adverse events is the term for them, and they can affect any organ and any tissue in the body. And about 80% of patients will get at least one autoimmune side effect from their checkpoint inhibitor. So this is part and parcel of getting these meds, is that you're extremely likely to get an immune-related adverse event. Most patients get bothersome things like rashes and thyroiditis, where they have to start taking Synthroid because they get an immune infiltration of their thyroid. That's the most common. But they can also be life-threatening. So patients can die from myocarditis, they can die from pneumonitis, and they can get severe acute kidney injury from nephritis, which is AIN. Is the biopsy finding. But it's really complicated because about 1 in 4 or 1 in 5 patients will develop an AKI episode within the first year of starting their checkpoint inhibitor, and there's a lot of other stuff. So here I have sort of some of the major single center series that have looked at the incidence of AKI in patients getting checkpoint inhibitors, and all of them come in between 17 and 25% of like all AKI. And then when you think about nephritis, it's really only between 2 and 5%. So the first thing you have to do is find which of the cases of AKI are autoimmune and what's sort of just the regular other stuff. So patients get dehydrated, they take platinums with their checkpoint inhibitor and they get platinum-related AKI. They get urinary tract obstruction from bulky intra-abdominal masses, and they get infections and sepsis. So you sort of, that's the first part of personalizing care, is making sure you have an accurate diagnosis. You should know that there's a difference in risk of AIN based on which checkpoint inhibitor someone's getting, and we consider these sort of class effects. So if they're getting combination therapy with 2 checkpoint inhibitors at the same time, then that's about a 5% risk of AIN. If they're getting monotherapy with PD-1 inhibitors, it's about a 2 to 3% risk of AIN, and the PD-L1 inhibitors have a slightly lower, maybe about 1% risk of AIN. So this is relevant when I'm thinking about a case, is sort of what regimen they're on. So typical presentation of AIN, the reality is there's not really that typical of a presentation, and it's very nonspecific, and there's no great way to rule in or out this diagnosis without a kidney biopsy. About half of patients will have a concurrent rash or thyroiditis or diarrhea from colitis, so they have some other autoimmune thing going on at the time you evaluate them for their AIN, but about half of them, it's the only adverse event. So they look totally fine, they've been tolerating their checkpoint inhibitor fine, and you're trying to figure out why their creatinine is 2, even though they're looking pretty fine in front of you. It typically comes on about 3 months after starting therapy, but that's not a hard and fast rule. We've biopsied people at the 4-week mark after just receiving a single dose, and we've had patients who were tolerating their checkpoint inhibitor for more than a year and then develop AIN. And that sometimes happens because another AIN med was introduced, like they started a PPI and then developed an episode of AIN. But sometimes that just sort of comes on, it's a little idiosyncratic, and it comes on late at about a year. And the urinary findings are really nonspecific. Our urinalysis and manual sediments are just, they don't pick up a lot of white blood cells. So whereas you may see them on a sediment, often you won't see it if you just do a urinalysis, and about 25% to 40% lack sort of urinalysis-based pyuria. And so you can't really be reassured by that, oh, there's no whites in the urine. That we've definitely biopsied a lot of patients with no whites in the urine who have AIN. So I want to go to sort of our first weighing and personalizing the decision about a kidney biopsy, whereas we'd love to have them on all of our patients and be sure of the diagnosis. I think the reality of clinical practice is that's not acceptable to many patients, and there's some harms of delaying delaying the time it takes to get the biopsy, and many of these patients are on blood thinners. So while we'd love to say that all patients should get a biopsy, when the patient's in the office, I'd say more often than not, I'm not sending them for biopsy. I'm trying to do my best to make sort of an empiric decision. And I can tell you the things that affect my decision making. So on the right side, the times that I am willing to just use prednisone and make an empiric diagnosis are when it looks like AIN. Right? So that means there's no significant proteinuria. When I feel like there's not hemodynamic disturbances, so when the patient wasn't sick enough to even need to be in the hospital, they look completely fine, their blood pressure is fine, there's no volume depletion and vomiting, then I feel more confident calling it AIN. And then of course, when there's high risk for bleeding, like someone on a blood thinner or someone who's already had a nephrectomy, those are the cases where I'm definitely gonna just make my best guess and give prednisone based on my best guess. I also feel like when they're receiving PPIs and other AIN triggering meds, that raises my antenna that it's likely to be AIN, so I'll often stop those meds and start prednisone. The times that I do push for kidney biopsy are things that don't look like AIN, so serologic abnormalities like a positive ANCA, proteinuria. We know that patients with AIN shouldn't have heavy proteinuria or heavy albuminuria. That would be a surprise and something I'd want a biopsy for. And hematuria, again, is not common with AIN, so that would make me want to do a kidney biopsy. This is becoming more and more common, but when patients are getting other things that could cause AKI, then I want a biopsy. If they are getting cisplatin and gemcitabine plus durvalumab, now you have 3 meds, all of which can cause AKI. And so I don't know which one to stop, and I don't want to have to stop all 3. So often I find that patients in that setting are actually very willing to undergo biopsy because they feel the same way. They don't want to stop all 3 meds when it might only be one that's causing the problem. And this combination therapy is now the majority of patients that are getting chemo with a checkpoint inhibitor, not just a checkpoint inhibitor alone. So that's become more complicated. And so those are patients where it's generally easy to align about a kidney biopsy. And then cancer, there are cancer-related factors that make me personalize my suggestions for biopsy. So you have to know which cancers are really where the checkpoint is just totally essential, and that's melanoma, that's certain lung cancers, and also microsatellite and stable colorectal cancers. So, and this is not something you have to memorize because it's always changing, but talking to the oncologist, like how important is the checkpoint inhibitor to this regimen? And so in those patients, I will often recommend a biopsy because if you pause the checkpoint inhibitor inhibitor temporarily or permanently, you're sort of robbing that person from a chance at cure. So I'm usually much more definitive about diagnosis when what I might be pausing or what I might be, the anti-tumor response that I might be obliterating might be robbing someone of a cure. Also, patients who are newly starting therapy, if they haven't, all of the tumors have a chance of these certain subsets of patients that have miraculous responses to checkpoint inhibitors. And so if the patient only got one dose, I'll often biopsy because they haven't yet gotten the chance to see if the checkpoint inhibitor is going to be sort of a miracle drug for them. So where someone is in their cancer journey and what kind of tumor they have is a part of why I personalize about recommending biopsy. But we definitely need non-invasive diagnosis. It's really, in many times it is really hard to get the patient to agree to a biopsy. They may be frail or at a place in their cancer journey where they're sort of done having biopsies. And so we and others are trying to identify and validate biomarkers that can make urine biomarker diagnosis a possibility. And so this is an important study that was presented or was published in JCI last year that Dennis Molodina and his group at Yale led that we helped contribute to, which found that urine CXCL9, which is an interferon-stimulated chemokine, is likely to be a very promising biomarker of AIN in the right subset of patients. That study is validated against biopsy-proven acute tubular injury, which is sort of our main diagnostic alternative. We're trying to say, is it ATN or is it AIN? And it had a promising ability to discriminate AIN in that setting. And we've worked on validating that in patients getting checkpoint inhibitors as well. Switching over to management, we withhold the checkpoint inhibitor temporarily. I'm going to talk in a few minutes about re-challenging patients after they've had an episode of AIN, but we always hold it while we're trying to treat it, while we're trying to treat the AIN. It's really important to stop meds that could provoke AIN. We really think that this combination of checkpoint inhibitor with an allergenic or an AIN culprit is part of the mechanism of why patients get AIN. The vast majority of patients are on another med that can trigger AIN. And so if they were on a PPI, I switch that to an H2 blocker. I think about what antibiotics they might have been exposed to. If they'd recently taken a course of Augmentin, we sort of make sure that they don't get penicillin class antibiotics again. And then we ask about over-the-counter NSAID use. And you'll find that a lot of patients had one of these three triggers around the time that they developed AKI. I do start with high-dose steroids with a mg per kg, sometimes 2 mgs per kg, depending on how severe the AKI is. And I will pulse patients with about 500 milligrams of methylprednisolone if they're in the hospital and their creatinine is very high. Definitely if they're on dialysis. 3 days of a pulse, and then after that I try to sort of rapidly taper their steroids. The sort of consensus is to begin the steroid taper once the creatinine is less than 1.5 times baseline. One of the things I want to talk to you about a little later in the talk is going a little bit faster than this and being a little bit more aggressive with how quickly we get certain patients off steroids. I think what's key is that in the early days of recognizing this as an entity, AIN from immune checkpoint inhibitors, people would give people long courses of steroids, and then with the steroids, they'd give them PPI and Bactrim, and a lot of patients wouldn't get better because we were giving them meds that cause AIN. So as you're prescribing your prednisone, you have to be sure you're giving famotidine as your ulcer prophylaxis, and if I'm using a prolonged course, I'll use a tovacone, but actually I usually use shorter courses, so don't use any PCP prophylaxis unless the patient's otherwise at high risk. And a multi-center study, the big study that came out with over 400 patients in it in the JITC in 2021 from Dave Leaf and Shruti Gupta's group showed that on average, patients were getting a 6-week steroid taper. So, that may be, that's a long steroid taper for anybody who's treated patients, and it's longer than we give for typical AIN. There's even debate, should we give any steroids for typical AIN versus just discontinuing the med? So I do want to challenge that this concept that every patient needs a 6-week course of steroids. I don't actually think that's true. I want to talk a little bit about AIN con meds and just review the data to sort of emphasize the point that this is a really important part of treating patients with immunotherapy-induced AKI, is recognizing that these other meds are playing a role. This is a guy I helped take care of, and we published his case in one of our publications. And he was treated with nivolumab for melanoma and developed an episode of severe AKI, had a biopsy, and was diagnosed with AIN. He was treated with methylprednisolone pulse as well as a prednisone taper, and his PPI was discontinued. He had a prolonged remission of his melanoma and then had a recurrence, you can see, about 2 years later, and was placed on atezolizumab, which is a PD-L1 inhibitor, tolerated that for about 6 months, until he started to get upset stomach and someone restarted his PPI. And then that 3 weeks later came in with a creatinine of 6. So it's certain you see enough cases like this that I think people who treat a lot of patients with checkpoint nephritis see a lot of this temporal relationship. We did also try to show this with observational data in our initial publication describing the incidence of checkpoint AIN in a cancer center, in our cancer center. We found that sort of once patients got out about 2 to 3 months from their checkpoint inhibitor, that PPI does seem to be a risk factor for developing sustained AKI events. And similarly, David Leaf in his manuscript noted that about 70% of patients were on another AIN med when they developed checkpoint nephritis. The next thing we considered as we started to review the data on single center studies looking at how, and also the Cortazar study, which is a multi-center study, about how often patients got better when we treated them with steroids. The answer was most patients overwhelmingly will come into a partial or a full remission when you give them prednisone. This isn't the case for all immune-related adverse events. There's actually, in the world of like cardiology and pulmonary, where they develop pneumonitis and myocarditis, a lot of times patients, those doctors are actually layering on multiple lines of immunosuppression. That's not really the case for nephritis. Most patients, not all, but most patients, if you stop the AIN meds and give them prednisone, they'll develop they'll have a full or a partial remission. There are second-line immunosuppression, and I'll show you some data, recommendations for second-line immunosuppression. I'll show you some data there, but I think this concept that most patients get better is really important for us as we're deciding how aggressively we should treat patients. And then here's the data on rechallenge. So I think our job when we're seeing these patients is to try to make them live as long as possibly, not necessarily have the perfect creatinine, especially if they have metastatic cancer. And so this is really important data from 2 multi-center series which looked at together this is about 31 patients who got rechallenged in the first study and then 121. So a lot of patients, about 150 patients who went on to get a checkpoint inhibitor again after they had an episode of nephritis. And you can see it's between 16 and 23% of patients who had another episode of ICI, AKI, or nephritis, recurrent nephritis. When you tell a patient those odds, they are fine to go. I've never met anyone who won't take those odds if their oncologist wants them to go back on the checkpoint inhibitor. So, it always depends on, whereas you or I may not want a 25% chance of getting recurrent AKI, patients with cancer who are worried about dying are generally willing to take these odds. So I always am recommending, I'm always sort of telling patients, we're just going to get you through this, and then if your oncologist wants you to go back on the checkpoint inhibitor, you're fine to go back on it, but you won't take your PPI again. We sort of try to lower the risk factors, and patients generally always take these odds. So again, just getting back to personalizing, I'm going to tell you a little bit about why I often will use shorter courses of steroids for nephritis, but just to frame when you may go down the path of long steroid tapers or more aggressive immunosuppression versus when you may try to push a little bit and try to use less immunosuppression and try to get a patient back on treatment. So personalizing. So first, let me tell you when I try to use a quick steroid taper and I try to push for rechallenge. So the most important thing is that there are no other life-threatening immune-related adverse events. Generally speaking, if I see them for nephritis and a cardiologist is seeing them for myocarditis, I just fade into the distance, because whatever that cardiologist is going to give them for myocarditis is going to be more than enough to treat their nephritis, right? That's such a more severe and life-threatening manifestation that I don't even have any opinions at that point. Whatever they want to do is fine. It's going to be enough immunosuppression for the nephritis. I'll follow along. But we have to realize that there are certain other immune-related adverse events like encephalitis or severe myositis, and these patients are completely disabled from those immune-related adverse events, and it's really up to the other specialist to decide on the steroid treatment. So when none of those are present, that's a time when I would consider that I'm in charge of the immunosuppression, and that's when I would consider, that's one factor that makes me consider sort of faster treatment. I think I definitely look at the pace at which their AKI is recovering. So that first creatinine check after I've started steroids is really important to me. If they're coming down nicely, then that makes me think I can get away with less steroids. So I often won't even tell the patient the full taper until I've seen that 5 to 7 day creatinine. When I see that other AIN meds were part of the picture and I know I can get rid of them, I also feel more comfortable that I might be able to get away with less steroids. So patient on a PPI, I take them off the PPI, start the steroid. In my mind, I'm thinking, stopping the PPI is such an important part of this that I'm probably going to be able to give less steroids. I only do this sort of rapid steroids in patients where it's just AIN. If I were to biopsy someone and see minimal change or another lesion, then sort of my immunosuppression would be based on that glomerular disease. Newly starting therapy, and again, these checkpoint sensitive tumors, I'm also very aggressive about not using too much immunosuppression. So if it's a melanoma patient and I know that oncologist wants that patient back on checkpoint inhibitor in 3 weeks, then I'm trying to do a 3-week or shorter steroid taper. So that's a really important factor of how important it is to me to get the patient back on treatment fast. The times when I don't use this approach, when I just say give the patient as much immunosuppression as it takes to get their creatinine better, I think that the factors that make me go in that direction are when the AKI is slow to recover. So you start the patient on prednisone 60 and then you check their labs in 7 days and their creatinine is barely budge, then I'm probably going to do another week of prednisone 60, and I'm going to sort of use that typical 6-week taper of steroids. I already mentioned that when there's other life-threatening IRAEs, like myocarditis, I'm in the back seat, I'm not the driver. There are other cancers that are not ICI sensitive. So a lot of the approvals for immune checkpoint inhibitors actually don't have an enormous benefit. And so I may use a little bit more prednisone in that setting because the oncologist is not eager to try to get them back on checkpoint inhibitor. And then I think it's really important, and I'm going to talk a little bit more at the end about patients who are getting adjuvant therapy. So checkpoint inhibitors are now approved for early stage cancers like breast cancer, people whose cancers have been fully surgically resected from their bodies. If that person who has a very long life expectancy develops a severe immune-related adverse event, I am going to be much more aggressive about immunosuppression because, one, they don't have cancer right now, and two, they have a really long life expectancy. So leaving them with only a partially recovered creatinine has a much bigger implications for their long life expectancy. Let me show you a little bit of the data that we put out about using shorter steroids for patients with nephritis. So we looked at our data at our cancer center, and at this point, it was mostly just me and Harish Sitapathy treating these patients. And so we decided we would give people like less steroid and just see what happened. And we felt like 6 weeks was overdoing it, and we wanted people to try to go faster. And so we changed our practice. And so the comparators here are sort of the historical practice in our center. And then we published the first 13 patients where we just decided based on our best clinical judgment that we wanted to use less steroid. And so our protocol was that, we stopped the other AIN meds, we held the ICI, we began prednisone, full dose, a mg per kg, and then we repeated the creatinine less than a week, 5 to 7 days. And as long as the creatinine was coming down by 25%, we then did a really rapid taper, 40 for 3 days, 30 for 3 days, 20 for 3 days, and then 10 milligrams daily. During that essentially 20-day period, we were repeating the creatinine weekly, and if it rose at any point, we restarted them back up at 60, and then we did sort of the standard of care, which is a 6-week taper. And what we showed in our first small study was that we could do this. We could get patients off steroids at an average of, a median of 20 days, whereas standard of care was more like 6 weeks, 38 days. And in our cohort, we did have to re-escalate 2 patients who failed, so 15% failed. But it turns out that in the standard of care group, also 15% of patients failed and needed to get more steroids. We also were able to get our patients back to their oncologist and getting another dose of checkpoint inhibitor really quickly at 20, the median was 26 days, compared to 135 days for patients who got sort of a longer, prolonged course of prednisone. And we didn't see a difference between the 2 groups in renal recovery. They recovered, the majority of them recovered, about 85%, whether you gave them a long or a short course of steroids. And then we talked with Shruti Gupta and David Leaf, and we said, let's see if we can try to replicate this using the multi-center data. And so we included 165 people and we could categorize them of short duration, less than a month, or long duration, more than a month. And they were able to validate this, which is that, regardless of whether you got a short duration or a long duration, creatinines were they came down about the same, and there was no increase in relapse. Some people do relapse, 5 to 10%, but it doesn't necessarily matter how much prednisone you give them. So I do take all of those factors into consideration of whether I'm giving someone a 6-week course versus a 2 to 3 week course. But at least we have some data here that we're not harming people by doing this. We just have to keep a close eye on them. The last data I'd like to cover is the data for relapsing disease, because we do have maybe 15% of people that will either finish steroids and look like they're doing well and then relapse when the steroids are stopped, or you give them steroids and they're refractory, their creatinine doesn't come down. And the best data here, which is a little surprising because nephrologists don't use infliximab, but the best data is with infliximab. And the reason why this group at MD Anderson chose infliximab is because that's what oncologists were giving to other patients with immune-related adverse events that were treatment refractory. So the colitis patients, pneumonitis patients, there was a lot of experience just giving these patients infliximab. And so this group used infliximab for relapsing or difficult to treat ICI, AKI. The majority of patients only got a single dose of infliximab, and 8 out of 10 of them had a partial or a full remission. So I think this is currently what's considered standard of care for treatment refractory or steroid refractory or relapsing ICI, AKI. I have given this to a couple patients and have also had good experiences with most patients having a partial or full remission. The last point I want to bring up, and I have mentioned this already, is that we have to think about adjuvant, because more and more checkpoint inhibitors are being given to patients with early stage cancers. And this is a really key area of where we personalize. And so adjuvants approved for lung cancer, melanoma, esophageal cancer, breast cancer, urothelial cancer, and RCC, and probably more are on the way. And really early stages of these disease, because they decrease the risk of relapse of that cancer. That being said, on average, each individual patient does not necessarily benefit that much from that checkpoint inhibitor. And if they're have a fully resected cancer, then their life expectancy on average for all of them is actually very long. So we did a paper that I think helps understand a piece of this, which is that cancer stage does not affect your risk of getting nephritis. Nephritis is based on the drug. So this is all AKI, where you can see the more advanced your cancer is, whether you have stage 3 versus stage 4, and we group the stage 4 melanoma patients into whether they got monotherapy or combination therapy, knowing that combination therapy is given to patients with more aggressive cancers. So the sicker you are with cancer, the more likely you're to get AKI. We know that, right? These patients are sicker, they may get infected, but the immunotherapy-related AKI is actually the same. So between stage 3 and stage 4, if you got monotherapy with pembrolizumab or nivolumab, you had the same 2-ish% risk of developing nephritis. And patients with stage 4, if you get combination therapy, if you get 2 checkpoint inhibitors, we know those patients are at higher risk of developing nephritis. But if you sort of compare regimen to regimen, these patients are at the same risk. And this has been proven across many immune-related adverse events that we do see adjuvant patients. It's a factor of the patient's medicine that they're receiving, not necessarily their cancer. So you do have to be really cautious about AIN risk in a patient who has an otherwise long life expectancy. So I think going forward, we want to know, can we use steroid-sparing immunosuppression up front for patients? And so I think we need to see more data about that. For now, the standard of care is still prednisone and using second-line immunosuppression only if someone relapses. And then can we predict who can become treatment refractory? And I think it's pretty clear we should be a little bit more aggressive for patients with adjuvant or early stage cancers. With that, I'm going to let Naoka come up and get her talk ready, and I'm happy to take any questions. Thanks. Did you want to come up to? Do you want to come up to the mic, or? Yeah, go ahead.
Like if you use steroids to treat this acute nephritis, so is it mandatory to give PCV prophylaxis? How many other disease, if you can find like steroid?
Yeah.
So in that case, we have to use.
I don't think it's mandatory, and I think especially I don't use it when I keep the steroid treatment to less than a month.
What about GI prophylaxis? We have to give Pepcid.
I think GI prophylaxis is still recommended for high-dose prednisone use.
Great. Thank you, everybody, for staying on. How many of you are transplant nephrologists? Gen Neph? Okay, great. I'm so glad the Gen Neph colleagues are here because, there are so many people being taken care of by general nephrologists and community setting as well as inpatient. So hopefully my talk will be useful for you. So I'm going to talk about the personalizing onconephrology care for patients with cancer after transplant. So this is my disclosures. And so today we're going to learn together cancer screening in kidney transplant recipients for common cancers as well as the high-risk population for PTLD and immunosuppression management for kidney transplant recipients. And I'm going to talk a little bit about novel therapies for cancers post-transplant, including immunotherapy. So the cancer is the leading cause of death for kidney transplant recipients. As you can see on the left-hand side, dialysis patients die primarily from cardiovascular causes, but the transplant patients die from cardiovascular causes, of course, but from infection and cancers as well. So, however, unfortunately, the death due to malignancy or cancer didn't decline over the past decades. This is a 10-year cause-specific mortality ratio for the patients with the kidney transplant. So as you can see here, cardiovascular and infectious cause of death decline, but the cancer-related cause of death in transplant recipient didn't decline. Actually, it went up a little bit. So we should do better. How can we do better? By personalizing cancer screening and prevention. Cancer screening and prevention post-transplant, we essentially recommend age-appropriate screening, and there's no strong data to suggest more intensive screening compared to general population. And how are doing, we're following the different guidelines, recommended slightly different guidelines from American Society of Transplantation, Canadian Society, and KDIGO UK Transplant Society, depending on available resources. But generally, we're recommending, first and foremost, skin cancer screening, total body skin exam, preferably by specialist, annual basis for all transplant patients. So this is the most important thing that, we as transplant nephrologists and Gen Neph clinician to recommend for kidney transplant recipients. Other common cancers such as cervical cancer, breast cancer, colorectal cancer, we're following the USPSTF guideline to follow a general population recommendation. So, however, it's a little sad to see that cancer screening uptakes remains low. So this is data from Australia, New Zealand, suggesting that post-transplant patient only do screening follow-up and maybe 30, 40, 50% for breast cancer, cervical cancer, and colorectal cancer. And looking at this data, we wonder why this is, and are the patients not interested in screening? The answer is no. Cancer is a feared outcome post-transplant. This is very interesting data from Australia and New Zealand again. They asked the number of patients post-transplant, best and worst scaling survey, and essentially they asked how many years of survival you can trade off to be off of any post-transplant clinical complication. And 93 kidney transplant recipients answered that they would trade off 3.2 years of allograft survival to be cancer-free. This is very interesting. And so what are the barriers for the cancer screening? So essentially to coordinate and inform and pay for all cancer specialists, GYN, dermatology, oncology are the barriers right now. So this is very relevant quote from Australian group, a qualitative study. I didn't get a pap smear for a few years and didn't get my skin checks done annually when I was supposed to do so because I was dealing with transplant issues and associated bills. So the person mentioned financial barrier here. A gynecologist or dermatology visit was yet another specialist cost, time of work, and frankly, an emotional drain. It's not a good excuse, but that was my reality at the time. So that is, I think, the comment that was relatable to our many patients. And, there's some financial issue, time issue, emotional issues going on in the clinic, in the reality. So how can we overcome the barriers? So I kind of suggest 3 points here. First, we should enhance patient awareness. We should engage patients for long-term goals, live longer, healthier, address concerns about over and under diagnosis, and we should work closely with the primary care and also general nephrology colleagues to share consistent messages to the patient. Secondly, we should remove and minimize the financial and healthcare burdens for cancer screening. We should advocate for policy to allow patients to undergo age-appropriate cancer screenings. Thirdly, transparent information sharing on the risk and benefit of immunosuppression reduction. We should tell the patient, hey, you got a kidney transplant, that's nice, but you're at the higher risk of cancer in the long term, and then we should be transparent about it and follow up during the clinic visit. So moving on to the high-risk patients for PTLD. So as many of you know, post-transplant lymphoproliferative disease, PTLD, is primarily B-cell malignancy, and it has bimodal incidence, early PTLD and late PTLD. Early PTLD happens 1 to 2 years post-transplant and mostly EBV positive, and then late PTLD comes 5 to 10 years post-transplant, mostly EBV negative. And the risk factors include the EBV mismatch, meaning the transplant from the donor EBV positive to recipient negative. So there have been shown that in the literature that 2 to 4% of the patients had a PTLD in the early phase within 1 or 2 years post-transplant. But there is one recent article that reassessed the risk of PTLD in a kidney transplant recipient with high-risk status. So this was a retrospective cohort study from 2 transplant centers from University of Pittsburgh and the University of Pennsylvania. They included adult transplant patients from 2010 to 2022, and they analyzed the prevalence of PTLD in 1 to 3 matched cohort, EBV high risk, 1 of 4 patients versus standard risk of 312 patients. So most importantly, they looked at every single patient's medical record to confirm the EBV serological status to avoid under or over reporting, which is important. And they looked at the incidence of PTLD and allograft and patient survival. So this is a key table from the publication. You see and highlighted here, patient with a PTLD percentage, comparing the EBV high-risk population on the left and standard risk on the right. So out of 104 high-risk population, 23 of them, actually 22%, had PTLD within 3 years of follow-up. And the median time to PTLD was 202 days, versus the EBV standard risk population, none of them developed a PTLD within 3 years. So this is very much higher than the historical numbers, and I'm going to come back to that. And in terms of the allograft survival on the left-hand side and overall survival on the right-hand side, there is not much difference in terms of the allograft survival and then patient survival. So the incidence of PTLD in the EBV high risk, donor positive to recipient negative, could be much higher than historically thought. So there are two potential explanations. One is the underreporting by transplant outcome registry. So we, all report to SRTR or USRDS database who or which patient developed a PTLD, but there might be missing diagnosis of PTLD in that report. And second possibility is that misclassification of EBV serostatus in the beginning. So some center or some patient might have been misclassified as EBV standard risk. The standard risk patient could be misclassified as an EBV negative recipient, and thereby diluting the PTLD incidence. We don't know. So this publication is based on two-center experience, and we should do multi-center validation to confirm the results. And in the publication, the authors discuss the appropriate frequency of EBV viral load monitoring, but there's no standard of practice how often we should monitor the EBV viral load. So that also needs to be figured out in the follow-up study as well. So moving on to the personalizing cancer treatment for the patient transplant recipients. So in addition to the conventional chemo, radiation, and targeted therapies, we consider immunosuppression reduction as a part of the cancer treatment in transplant population. In assumption of immune surveillance of cancers, we often hold or reduce antimetabolites, especially azathioprine, and we can consider conversion of calcineurin inhibitor to mTOR blockade, and this has been supported by tumor-RAPA trial that I'll talk in a few slides later. However, we face challenges in cancer treatment post-transplant. So as I mentioned, we do reduce the immunosuppression, but that is actually increasing the risk of allograft rejection. So you can see three pillars of the post-transplant management. Of course, we would like to minimize the risk of allograft rejection on the right-hand side, but at the same time, we like to lower the risk of cancer and the infection complications. So right now, if we do too deep immunosuppression, as you can see here, we might be able to avoid the rejection and maintain the tolerance situation in the allograft, but that can also put the patient on a higher risk of cancer growth and infection. But by reducing the immunosuppression, we're actually maybe doing better for cancer immunity and infection prevention, but that would put the higher risk of the allograft rejection for the patient. So that is a real clinical conundrum. So going back to the immunosuppression management, conversion to mTOR blockade, such as sirolimus, everolimus, is actually shown to be beneficial for patients with a history of skin cancers. This is the tumor-RAPA study group. They had a randomized trial, and the kidney transplant patients with a history of skin cancers randomized to the group that stays on a calcineurin inhibitor versus the group who were converted to sirolimus. As you can see here, this is a probability of survival-free squamous carcinoma. And then if the patient were converted to sirolimus, which is mTOR blockade, they had a lower risk of recurrent squamous cell carcinoma. So this is now a standard practice for kidney transplant patients with a skin cancer. However, we should be cautious that mTOR blockade conversion was not associated with a lower risk of non-skin cancers. As you can see on the right-hand side, non-melanoma skin cancer, you clearly see the benefit of mTOR conversion. This is a risk of cancer. You can see in the dotted line, if the patients are on mTOR blockade, the hazard ratio of developing a skin cancer is lower. However, as you can see on the left-hand side, if you look at the risk of all cancer without skin cancer, there's no benefit of being mTOR blockade. And there is one systematic review and meta-analysis show that if the patients are on mTOR blockade, they're at a higher risk of cardiovascular death. So we should be aware of the risk and benefit of mTOR conversion when the patient has a cancer. So moving on to the newer therapy, I'm going to talk about the checkpoint blockade and as well as oncolytic viral therapy as an example. As you heard from Dr. Saiz much about the checkpoint blockade, so I'm not going to talk a lot about the mechanism, but there are 100 and plus cancer species that got FDA approved, and the immune checkpoint blockade unleashed the brake against the cancer immunity. Thereby, T cells can be fully active and can kill the tumor cells in the periphery. So we learned a lot about what happens for the patients in general without transplant, but we quickly learned that patients post-transplant have higher risk of rejection when they're treated with a checkpoint blockade. So this is a results from a multi-center study that was published in 2021 in Kidney International. We collected 69 cases from 23 institutions, and we estimated the risk of rejection as 42%, and time from checkpoint blockade to rejection was very quick. It was around 3 weeks after initiation. And when we do biopsy, for these patients with the AKI, we saw both T-cell mediated rejection as well as mixed T-cell mediated and antibody mediated rejection common. And unlike in the non-transplant patients, these AKI can be very severe. And once rejection happened, 65% of patients needed to go back to dialysis. And in our multivariate analysis, we suggested that mTOR blockade, sirolimus or everolimus, associated with a lower risk of rejection. In terms of the tumor outcomes, we saw that there will be some increased overall survival in patients with a cutaneous squamous cell skin cancer subgroup. As you can see, when the patients are on immune checkpoint blockade shown in blue line, they live a little bit longer compared to historical cohort that were treated non-checkpoint blockade. So this is this table summarized kind of back-to-back or side-to-side comparison of the clinical characteristic of checkpoint blockade-associated AKI. So kidney transplant patients at the higher risk of acute kidney injury, and it happens much faster compared to GenF population, and they're much more steroid refractory and severe, 60 to 70% patients requiring dialysis. So the next million-dollar question is how or whether we could mitigate the rejection in this challenging population. So this is a list of clinical trials of checkpoint blockade in kidney transplant recipients. There are 4 of them. 3 of them on the left have been already published. So the first one was nivolumab in transplant recipients. They recruited 17 kidney transplant recipients with any sort of cancer treated with a nivolumab. They saw 12% rejection risk and keeping the same regimen of immunosuppression. The second and third studies were published last year back to back. The tacrolimus and checkpoint blockade study recruited 8 patients with a kidney transplant history with skin cancers treated with a nivolumab and ipilimumab. They saw 25% risk of rejection. On the other hand, we conducted a contract 1 study, which is a single center study. It recruited 12 kidney transplant recipients with a skin squamous skin cancer treated with semipilimab, which is anti-PD-1, using mTOR blockade and dynamic, a little bit higher dose of prednisone, which I will touch on in the next slide. We saw 0% rejection, which is great. So based on this success in Contract 1 study, right now there is one ongoing clinical trial looking at the risk of rejection in a little bit larger population in the skin cancer with kidney transplant recipients. So what exactly we did in the Contract 1 study is, converted all the patients to mTOR blockade with 4 to 6 nanogram per ml trough level and using prednisone 40 milligram from the day prior to the immune checkpoint blockade infusion and taper down very quickly every 3 days to 20 milligram, 10 milligram throughout the course. So hope this, the study would become a standard of care in the future, and then looking forward to seeing the upcoming results from the ongoing study. So for this challenging population, however, we can probably personalize how we treat the patients with skin cancer. So what if the patient has a regionally advanced lesion? The skin cancer is very visible and then localized in certain area of the body. So in these cases, probably can offer a little bit different therapy. And I'd like to share newer therapy called TVEC. So TVEC is attenuated engineered herpes viruses. We can use these attenuated viruses to enhance the tumor immunity in the body. So how it works is that oncologists, inject this TVEC viruses into the skin lesion, and viruses target the cancer cells and kill them. And then the dead cancer cells release the tumor-related antigens, and the body's immune system recognize this antigen and provoke the anti-cancer response. So it's now approved for various cancers, including skin cancers. And so we are now having the transplant targeted clinical trial, ARTACUS trial. This is for phase 1b to 2 study of this oncolytic virus in the solid organ transplant with advanced cutaneous malignancy. So really kudos to the study group, because they want to enhance the cancer immunity and keeping the infection risk in the middle, because we don't want to kill all the oncolytic viruses, and at the same time keeping the rejection at bay. So they included 27 organ transplant recipients, of which 22 was the kidney transplant recipients, and they recruited the cutaneous skin squamous cell, 24 of them, and then 3 Merkel cell patients. And objective response rate was 35%, which is not bad. They didn't have any rejection episode, but they didn't standardize the immunosuppression. So we should do a little bit more detailed study to focusing on immunosuppression management. One thing I'd like to mention for the oncolytic virus therapy is the HSV dissemination. Of course, these patients are on immunosuppression and you're injecting the viruses to the body. So this could be expected. So this is kind of showing the picture from the case report. This patient has melanoma and treated with a TVEC therapy, and a few days later, this patient developed a rash in the leg, and then also some mucositis from the virus-like prodrome, and the TVEC was detected in the circulating peripheral blood, and it was diagnosed as HSV dissemination from the TVEC. So, but thankfully, these TVEC therapies are attenuated viruses, so this can be quickly treated by acyclovir and valacyclovir, and the patient did fine, and you can see the regional melanoma was gone after 2 years and keeping the remission. So, summary of the TVEC therapy, it can be a potent localized therapy for cutaneous cancers, but we should be aware of, the disseminated infection risk of oncolytic viruses. So future of cancer treatment and organ transplant, we need more epidemiology data. We have the registry data, SRTR and USRDS, but they don't report cancer outcomes in a standardized way. And so probably we need to add the cancer registry for the treatment, the transplant recipients. And we should implement the co-management models that we can take care of patients with cancer together with oncologists. And ideally, in the future, I'm hoping that we could develop a targeted therapy that can uncouple the cancer-directed immunity versus alloimmunity. So it's kind of, to visualize kind of goal. So right now we're doing in the left-hand side, increasing or decreasing the global immunosuppression. But, as we encounter the challenges in the future, hopefully can, manage the cancer and the infection control, but keeping the allograft rejection risk in the lower end. So to conclude, kidney transplant recipients are at the higher risk of cancers, and personalized cancer screening, immunosuppression management, and treatment choices are encouraged. And we should really emphasize the multidisciplinary team approach, including transplant clinicians, patient care partners, oncologists, surgeons, radiologists. We all should be empowered to make changes in immunosuppression and modify risk of rejection and novel immunotherapies. With that, I'd like to thank my team at WashU and Sightline Cancer Center, as well as Brigham and Dana-Farber colleagues and patients and family, and happy to take any questions.
Fantastic. Thanks so much. Does anybody want to come up to the microphone and ask Dr. Murakami a question? Great.
Could I ask a general one? This more applies to you.
Oh, yeah, that's fine. Yeah, but there's a lot of questions in the chat. I'm trying to respond to some in the chat, but people can also ask now and also come up afterwards. We can stick around a little bit. Yeah.
Actually, a patient I have, I live in Maine. He was diagnosed with lymphoma after serving in the Gulf War. They contributed to that. Anyway, he went through treatment. They put on, I can never say that right,
Nivolumab, yeah.
Exactly. He got one dose of that and then had an increase in his creatinine with proteinuria. So the oncologist actually treated him with steroids, pretty high dose steroids. Their regimen, I think, a couple of weeks, and it actually improved, but then he relapsed. So then he was referred to a different nephrologist, went down there, they put him back on high-dose steroids, but then he had a terrible gastritis with a GI bleed. He had been on a PPI for a long time before all this stuff started. So they got a biopsy, it showed checkpoint or interstitial nephritis. Yep. He didn't get the second dose of the Opdivo. At that point, because of the GI bleed, they cut down the steroids. The biopsy showed an interstitial nephritis, gave him infliximab, one dose. That didn't work. Creatinine was still going up. Then he gave him, tacrolimus? There was another medicine they gave as a one-dose thing. That didn't work. Creatinine was up to 6.9. At that point, they say he's really high risk for steroids, probably going to need dialysis. Came to me because we know each other for a long time and said, I don't know what to do because of the other stuff. They didn't want to put him back on prednisone. But that worked. So we actually, with working with, he got put back on the PPI. We put him on the steroids. We got him back on the H2 blocker with Carafate intermittently. And his creatinine is now down to 1.9, which is still above his baseline, but better. The proteinuria is down to about 600 milligrams. My question is we've been slowly titrating down the prednisone. It's kind of stuck there. Once we get down to 40 milligrams, that's where we start seeing the bump up again. Time frame, I'm not sure what to do with this because
that's a hard one.
Because the other thing is I started looking at other things. Do you treat it like other chronic interstitial nephritis is? Everybody's like, you can't use mycophenolate. You absolutely can't use that. That's the roadblock I hit. I don't know about the other agents. I'm not really sure if we can't titrate him down over time. I'm still hoping he'll be able to wean, but where do we go if it's?
Yeah, I've used some salt. I mean, I've used some mycophenolate for sure as a steroid-sparing agent. And then I think there's case reports of ruxolitinib, which is Jakafi, as sort of that really targets interferon pathway. It's likely to, that agent is likely to really obliterate anti-tumor effects, but might be effective in a really refractory AIN
As
case.
soon as you talk about lymphoma, everybody's like, oh, you can't use the antimetabolite, you can't use cell.
I see, because of the risk. I think they'll probably say the same thing about ruxolitinib, but,
Yeah, okay.
and how many doses of, you could also try another dose of infliximab now that you have them in a little bit of remission and just see if that helps.
Okay, great, thank you.
Anybody else? See if there's anything. Sorry, I'm having a little trouble following all the questions in the chat. There was a question about like how long after a patient develops checkpoint AIN and could you institute steroids? There's two things in the question. One is how long after the last dose of checkpoint could you start steroids? So I think the first thing is that patients, those drugs, checkpoint inhibitors all have long half-lives. So a patient could have actually switched to another line of chemotherapy, but still have received a checkpoint inhibitor 3 or 4 months earlier, and it can still be checkpoint nephritis because of how the long half-life of the medicine. So sometimes you will see patient hasn't gotten a checkpoint inhibitor in 3 months, but they have an episode of AKI, and you do have to consider AIN. And then this question of like how long after an episode could you start the steroids, I think there's good data showing that the longer after AKI has come on, that like there is a delay to steroid treatment, then the less likely it is to fully recover. I think, that's just that some of these cases are so such a robust AIN, and there's so much cortical involvement that if it's left unchecked, you're going to have tubular injury and interstitial fibrosis that can develop pretty quickly there. So I think, getting someone on steroids pretty quickly is important, and that is one of the reasons why sometimes you don't even have time to get a kidney biopsy because of delays. If it's not an inpatient at our center, it's, a week or 2 weeks to get a kidney biopsy. So often that does affect our decision making. And so I think in a severe case, especially, you really want to get the steroids going as soon as possible. Let's see. Anybody else have any other questions? All right, great. Thanks so much for joining us today.